Good evening to everyone who have joined us virtually today from different parts of India. Warm regards from Indian Society of Prenatal Diagnosis and Therapy. We are truly delighted to have you all for our episode 1 of genetic testing in clinical practice from screening to diagnosis. I'm Dr. Ankita Shah, coordinator for today's webinar. I'm extremely thankful to Dr. Milind Shah sir, our president, and Dr. Purnima ma'am, our secretary, to have trusted me on this webinar. No society can progress and work efficiently without the able guidance of a president. We are truly privileged to have with us an enthusiastic, ordinary, and inspirational leader, our president, Dr. Milind Shah sir. He is consultant at Naval Maternity and Nursing Home at Sholapur. He is honorary secretary of Federation of Asia Oceanic Perinatal Sciences. He is ex-president of Indian Society of Perinatology and Reproductive Biology. He is currently professor and HOD in Department of Obstetrics and Gynecology at Gandhinatha Hospital and Medical College. He has visited multiple countries to deliver lectures in various topics in ultrasound and obstetrics and gynecology. He has authored a book on hypertensive disorders in pregnancy, pelvic organ prolapse, and has contributed to more than 20 chapters in various textbooks. He has published multiple papers in national and international journals. We look forward to your valuable insights, sir. Over to you.
Is the slide on? Was it on? Because I didn't
No,
see it.
no, it wasn't.
No, it was not it on. Yeah,
All right,
good.
no problem.
Yeah, no worries. Yeah. Well, thank you very much, Ankita, for those kind words, friends. Let me welcome you all. ISPAT is a wonderful group, I would say, and I got the good friends actually because of ISPAT, Indian Society of Prenatal Diagnosis and Therapy, which puts a lot of light in the all those clinicians who are in association with this organization. And that's why when Dr. Purnima called me and told about this venture of the MedGenomics, and she wants to start these episodes, I was immensely happy because these are the tests which come in the market, but quite often people they don't understand the all those intricacies involved with that. For example, quite often on various platforms, I hear patients saying or the clinicians saying that nowadays we don't do screening, we directly do the NIPT. And then sometimes I get amazed. Is it really true? But the friends like Pratima and Chinmay always come to our rescue to solve all those actually problems. And that's why not only the very young gynecologists, but very senior gynecologists also go to them to learn about all those things related to the fetal medicine. And that's why I'm extremely happy to have this association of ISPAT and MedGenomics to have a wonderful deliberation. I'm looking forward to Dr. Priya, to you, to understand about this tiny thing you are saying, but yeah, it circulates in the maternal blood and which we can catch. But yes, while doing that, it has to be done very, very meticulously because we have seen that era. Previously, the sample used to go to Hong Kong when we started sending in 1990s. And they always used to say retrieval is not adequate, less than 3%. Report cannot be given. And the days came that the technology advanced and that hinge which was there of the adequate retrieval has gone. But same time, we started realizing newer and newer things about this test, and we are understanding now even the advanced NIPT also is another option which we can judiciously use it. And that's why when Purnima said wonderful cases we need to discuss, I was again more happy because these are the cases which put more torch about what actually happens. The patient comes to you practically. What the viewers or the conference delegates want, they want what we do in our clinical practice, which will be useful not only to the patients but also the clinicians. So, with these notes, I'm welcoming you all for this wonderful webinar. It will be good interaction of the knowledge, but I would say good learning as well. So, Priya, Ami, Chinmay, Pratima, we want to hear from you what you say about it and let us see what we can add in our practice as well. Thank you very much. Once again, thanks a lot for this wonderful opportunity.
Thank you.
Thank you so much, sir. Moving forward, I would like to now introduce our dynamic secretary, Dr. Purnima Satoshkar ma'am. She's played an instrumental role in leading the society and bringing together today's webinar. Her dedication knows no bound. Dr. Purnima ma'am is currently a consultant at Just Lok Hospital. She is former HOD, a professor and HOD at St. G.S. Medical College and Navrojji Wadia Hospital. She is chairperson of AICC RCOG. She also has bagged multiple awards. She has more than 40 chapters in, she has more than 40 publications in national and international journals. She will now introduce to us our guest of honor, doyens of fetal medicine, Dr. Chinmay Ratha ma'am and Dr. Pratima Radhakrishnan ma'am. Over to you, Purnima ma'am.
Priya, can you
share the
Yes.
slides? Yeah, I'll do that.
So I think it's a great privilege for me to introduce my two friends and very, very dynamic fetal medicine experts who are here today. And we are really happy that both of them could join us. Next one. Yeah. Okay. So Dr. Chinmay Ratha is here. She's a FRCOG and a Diploma in Fetal Medicine from FMF UK, Director and Lead Consultant Resolution Center of Fetal Medicine. And she's a very, very active member. She's been in FOGSI in the Perinatology Committee. She's won several awards, the CL Zaveri Symposium Award, Meru Hansutia Award for Best FOGSI Committee Chairperson, and large number of prizes. There's no time to read all of them. But welcome, Chinmay. I know how dedicated you are to fetal medicine, and we'd love to hear your views on the topic. We also have with us Dr. Pratima Radhakrishnan. She's again an FRCOG and she's been trained with Kypros Nikolaidis, and she's written here, role models are Kypros and Professor Lindsay Allen, but Pratima, you are a role model for a lot of us. And she's the director of Bangalore Fetal Medicine Center, first to perform therapeutic fetoscopic laser in India, and really very well versed. I've sent her a patient recently and she really managed the patient very well. And she's delivered several orations. She has many publications, and she's very actively involved in teaching. And whenever this Bangalore Fetal Medicine Center has their webinars, we like to tune in. So once I was going to catch a flight and it was clashing with the webinar. And when I went to the airport, the flight was late by 2 hours. I've never been more happy. I listened to that webinar on twins and it was really wonderful. So welcome, Pratima. We want to hear your views.
Yeah. And the best part, Purnima, the other day I just wrote a message to both of them. We are doing this new venture. Will you please come as a guest? And you cannot believe, within 1 hour, both of them, they considered so positively. Both of them, they had come to even Sholapur for delivering Dr. Shirodkar oration, and every time they were mesmerizing the audience. So we are looking forward for your expert opinions about this NIPT. Yeah.
Yes,
Yeah.
Ankita.
Yes, please continue.
Thank you so much, Purnima ma'am. We are truly grateful to have Chinmay Ratha ma'am and Pratima Radhakrishnan ma'am. Moving forward, NIPT is fairly a new technology and is advancing day by day. I'm thrilled to introduce to you our guest speaker, Dr. Priya Kadam ma'am. She is Director of Reproductive Genomics and heads the Reproductive Genetic and Genomics section at MedGenome Labs. She has worked tirelessly in the field of NIPT. She has done groundbreaking research in genetic testing and cancer biology at Singapore. She holds a patent in prenatal testing granted by the US and China. She has had multiple academic contributions. And she has also published a chapter on NIPT in preventive genetics. She has co-authored the FOGSI guidelines for NIPT implementation in India. She is a speaker at multiple national and international conferences. She holds membership of esteemed institutes. Today she is here to talk about tiny DNA big answers implementing NIPT in clinical practice. This is particularly timely because of the current use of NIPT is on the rise. Please join me in welcoming our speaker, Dr. Priya Kadam ma'am. Over to you, ma'am.
Thank you. Thank you, Dr. Ankita. It is my pleasure to be here actually in presence of all esteemed faculty in this space. I'll start. Thank you very much. So you'll introduce Dr. Ami as well?
Yeah, do that now that she's flashed the slide.
Yeah.
It's okay.
Yeah. So our next speaker is going to be Dr. Nisha ma'am. She is consultant in clinical genetics at multiple hospitals in Mumbai. She is attached to multiple prestigious institutes. She is advisor and consultant at MedGenome laboratories. She is on board for future leaders of ICNA and member AFC Gender Eligibility Panel of Experts. She has published 10 articles in national and international journals. She has also chaptered genetic. She has also chaptered chapters on genetics. Her field of interest is fetal genetics, neurogenetics, neurometabolics, and academics. I welcome Amisha ma'am.
Thank you.
So,
Ami is very down to earth, but her opinions are right on the absolutely correct every time. So if you have a doubt, you can just send her the
Appreciate.
proband
I think today I am.
and the reports.
I think today I'm more like you. I'm going to be a student because I am also waiting to hear Priya ma'am and also the experts who are around. So I would be more of
Yeah.
listening than commenting.
Correct. You can start, Priya.
okay, thank you, Dr. Podema. It is indeed a pleasure, and I'll dive straight into the lecture. So the outline would be what is the need for screening for chromosomal abnormalities. I think the crowd is a mixture of different backgrounds, so I'll go into the nitty-gritties as well. So that, and then we need to understand a little bit about where NIPT comes from, what is the background, so that we can implement it well. What are the common clinical indications that it is indicated for, where it should not be done? And also, what are the key testing parameters? These are very important because we need to understand several aspects of sensitivity, specificity, what is PPV, all these factors, so that we can compare tests and understand performance. I'll also touch upon guidelines, what the international guidelines have been saying and what we have developed in collaboration with others, which was written in Foxy, and also what are the nuances of doing NIPT in twins, in rare autosomal aneuploidies, vanishing twins, should you do it or not? What about microdeletions? And of course, there are some specific genetic counseling aspects which you may be doing, but I've just put it together so that it's a ready reckoner when NIPT is offered. There are certain limitations as of now, and those need to be understood. Future directions, which I'm extremely excited about, and also conclusion finally. So now, as I think most are medicos, and we all know that screening for chromosomal abnormalities is important because every pregnancy carries a real risk of fetal aneuploidy. And these are major conditions which have a lifelong impact. And that's why when screening is necessary, of course, it enables informed decisions and allows for diagnostic follow-up. It improves pregnancy and neonatal care. And also, what is very important and usually underemphasized is it provides reassurance in low-risk pregnancies. And we know that every professional society does recommend some form of screening for all pregnancies. So, this is taken from Prof. Verma's paper. We know that incidence of chromosomal abnormalities is about 1 in 150 to about 1 in 200 pregnancies, and that is a significant number for offering screening for all pregnancies. Now, when we look at genetic tests, it's very important to identify and understand the difference between a screening test and a diagnostic test. We know what a screening test does is it changes the prior risk. So after the screening test is done, the screening the risk either increases or it decreases. While a diagnostic test will give you a definite answer whether the condition is there or not. Now, while we think of chromosomal abnormalities, we know the earliest screening test was maternal age, followed by maternal serum screening and ultrasound. And all of this had varying levels of accuracy or sensitivity and specificity. So today we are going to focus on NIPT, which has the highest sensitivity and specificity for chromosomal abnormalities. And there are certain conditions where a diagnostic test may be more appropriate directly. This is especially in situations when you're specifically looking for a specific genetic disorder, which may be a single gene disorder, or you're looking for a specific SNB. In that case, a diagnostic test may be a direct, you can actually skip the screening test and go straight for diagnostic test, where you will also look for aneuploidies. There may be other conditions in which you may see several abnormalities on the ultrasound, and Dr. Pratibha and all the other dignitaries here would be able to say that there are certain situations in which NIPT may not be appropriate. Of course, for diagnostic tests, the most common or the quick ones will be QF-PCR and FISH, which will give you a very quick answer, followed by genome-wide testing for chromosomal microarray or low-pass whole genome sequencing or a karyotype. And sometimes, off late, there is a lot of information of going for exome first. That means NGS-based testing, because NGS can also identify CNVs, which are identified by CMA or LPWGS. So now going into non-invasive prenatal testing, it has been known for years that there is a bidirectional flow of genetic material from the mother to the fetus. Now, this can actually be anything. It can be fetal cells, it can be fetal DNA, it can be fetal RNA, and all individuals actually have some amount of cell-free DNA in them. So what is non-invasive prenatal screening? In this context, it is testing the cell-free DNA to identify abnormalities in the fetus. It could be trisomies, it could be microdeletions, it could be rare autosomal aneuploidies, or it could be other conditions. And the thing is, because it is a blood draw from the mother, it is safe and it is non-invasive, or minimally invasive. So there are certain facts about the cell-free DNA which we should be aware of when we offer NIPT, because one thing is there is just a fraction of the cell-free DNA which is fetal. The rest of it is maternal. Every individual actually has cell-free DNA, or the DNA which is outside the cells floating around in our plasma. But when a woman is pregnant, by as early as 4 weeks onwards, you can actually detect this in the maternal plasma, and it is this which is used for testing. And we have to very much remember that this cell-free DNA is known to come from the placenta. Why this is important? Because 99% of the time, the genetic makeup of the fetus and the placenta is concordant, but about 1% of the time it may be discordant, because there may be, say, a mosaicism in the placenta called confined placental mosaicism, and this does have an impact on NIPT results. The proportion of fetal DNA can be anywhere from 2 to 30% or more. And another important point to remember is it clears rapidly after delivery, because once the placenta comes out, it disappears within 24 hours. So why this is relevant is because the testing which is performed is for that particular fetus. Why I mention this is because fetal cells, intact fetal cells are known to last in maternal circulation or maternal body for as long as 27 years. And that's why we make the distinction is this, we want to know, because we are trying to test for a current fetus. We know that NIPT has been widely accepted worldwide from the time it has been commercially available. This is our graph. We do see uptake in the trend, and those stars over there are our publications associated with the study and the data that we look at. Now, how has the scope of NIPT expanded? Of course, it was identified in 1997 when you identified the Y chromosome fragment in a woman who was pregnant. So that was coming from the fetus. That's how the discovery happened. And most people may be surprised to know the earliest application has been to identify fetal genotype in Rh negative mothers, which was way back in 2010. After which, it became available for, of course, trisomy 21 first, very quickly followed by trisomy 13 and 18, sex chromosome abnormalities, microdeletions, and then genome-wide testing. So we look at all chromosomes, twin pregnancies, and single gene disorders. Now there have been there has been research on more applications of which I will come to in a bit. Again, I'm coming to screening parameters, which are very important because we want to have a screening test which performs in such a way that if there is a disease, it should be able to pick it up. That means that's a true positive. Or if there is no disease, it should say the screen should also be negative. That is a true negative. So the first aspect, the true positive, talks about the sensitivity, and the true negative talks about the specificity of a test. Why NIPT trumps is because it has very high a level of sensitivity and specificity. Of course, we don't want the test to be positive and the fetus not have the disease, which is a false positive, which is still okay. But what we absolutely want to avoid as much as possible is a false negative. That means your test is negative, but the fetus actually has the condition. There are two other parameters which are again very relevant for a screening test. That is a positive predictive value. What is a positive predictive value? That is, how likely is it that the fetus is truly affected given a high-risk NIPT result? This is actually the differentiator between NIPT and maternal serum screening. True negative also is very important because your screening test has said it is low risk, and then you don't really have to worry in most cases. So now, why is it? These are the factors where NIPT trumps because it has the highest detection rate, it has a low false positive rate, and it is gestational age agnostic from about 10 weeks of pregnancy. And it is the earliest that you can get results for chromosomal abnormalities. Of course, the scope is increasing. Only thing is that it doesn't look for neural tube defects, and some counting technology actually does not identify triploidy also. And better counseling in that, if it is a if it is a high risk result, it is most likely to be affected. So this is the classic study which was published in 2015, which compared the performance of NIPT against standard screening by Mary Norton. And what you can see here is the sensitivity, of course, specificity and sensitivity and specificity over here is 199 for trisomy 21, and for standard screening it's about 79 and 94. What is the major differentiator is the positive predictive value. So when you have a high risk result on NIPT, the likelihood that the fetus is affected is here it is 81%, and by standard screening it is only about 3.4%. So similarly, for trisomy 18 and 13 as well, you see the major difference in the positive predictive value, which is 90 for NIPT and 14 by standard screening for trisomy 18, and for trisomy 13, it will be 50 and 3.4. And the other factor is, what is the false positive rate? False positive rate, we know with standard screening goes to about 5%. It is chosen around there. But with NIPT, the false positive rate again is extremely low, though false positives, many of you would have come across false positives on NIPT as well. Now, what do the international guidelines say? We have been tracking it from 2011 because it first became available. All societies had initially recommended that NIPT be offered only to high-risk cases, but with the improved performance, with costs being managed, it seems that, and all societies from 2020 do state that it is the most sensitive and specific test, and therefore it can be offered to all patients. And in India, of course, we worked with Foxy, me and my colleague Angela. It was ethic evidence-based recommendations. So there were a set of questions which we worked on, which gives answers. And this chapter 6 in this book gives answers on when should NIPT be offered, what is the right time, what is the optimal fetal fraction requirements. So we do have some evidence-based suggestions here. This has, of course, been curated by the editor and other experts. So there were guidelines, and then there are certain Indian adaptation of how this testing has to be done, and these are some of the publications. Now, how do you do NIPT in the clinic? Of course, the first essential step is pre-test counseling, because I do have a slide on counseling again later on. Sample can be collected anytime from 10 weeks of pregnancy. There is no upper limit technically, because we can do it anytime from 10 weeks onwards, even right before delivery, but the utility is what you would want to see. And results are available about a week or so, and results can be either high risk or they are low risk, or there may be no results. If there are no results, what is to be done, that I will mention. And of course, the follow-up has to happen. This is one parameter that you have, or one test result which you have in the management of the entire pregnancy. So what are the common clinical indications? Of course, advanced maternal age seems to be the most common even in our data. And of course, we see that in India, most clinicians prefer to use NIPT as a contingent test. That is, if there is a high risk on first trimester screening or quadruple screening, sometimes when there is an isolated a soft marker like a EIF or echogenic kidneys, they might want to do an NIPT first. If there is a previous pregnancy with aneuploidy, and the proportion of maternal anxiety right now is increasing slowly. And there are certain special scenarios. What about twin pregnancies? I'll come to the details of that. IVF ART, I mean, it performs very well in IVF and ART pregnancies as well. Initially there was some questions about it, because it was sometimes associated with low fetal fraction, but later publications have not supported it. And when there is a high BMI, when you see the patient and then you see that, okay, she may be slightly on the high weight and BMI side, or obese, the only intervention maybe at that moment may be a caution that there may be a redraw which is required. And Rh negative women, we can do the Rh genotyping. That is one of the applications, of course, not for aneuploidy over here. And when where there are precious pregnancies and they do not want to go for invasive tests, this can be an alternative. Of course, NIPT is not validated for multiple gestations beyond twin pregnancies, though there are some publications and some work going on right now. If there is a recent blood transfusion, and also in case of maternal malignancies, because this is something which I'll speak about a little more. If it is a known case of maternal malignancy, it may be better to inform, or you will have to use it with caution. Or if there is a maternal abnormality, which will again speak about a little later. And if there is a case of vanishing twin, should an NIPT be sent or not, we will speak about it. We do accept it, and it does have some nuances to it. Now, looking at our data, we see that most common, 25% of the cases, it is used as contingent screening, which is high to intermediate risk on maternal serum screening. Advanced maternal age independently may be a factor. There are multiple indications in some other situations, but unfortunately, about 30% of the time, we don't really get a clinical indication on the TRF. And this is something which I would like to request everyone to just give a simple reason why an NIPT is being performed. It could be anything. It could be 1 in 150 risk on first trimester screening. It could be EIF something. A blank TRF actually is not very helpful, because we do monitor the parameters. We look at what should be our thresholds, whether our thresholds should be changed based on so many such factors and clinical inputs. So once an NIPT NIPT sample is sent, what is the distribution of results? The good thing is about 98% of the time you're going to get a result. It could be either high risk, 2 to 3% of the time it could be 2 to 3% of the time it could be high risk. About 95% of the time it is a low risk result, and in about 2% of the time, 1 to 2%, a redraw may be requested or the test may fail. Now, when the test may fail, there will be a recommendation. The recommendation may be that the redraw is requested after 2 weeks, or sometimes we may not request a redraw. So why that happens, in certain scenarios it can happen, and then a redraw should not be sent. So if you send a redraw when a redraw is requested, about 60 to 80% of the time you're likely to get a result. Of course, for basic screening, the most common abnormality will be trisomy 21, followed by all other conditions. And what I'm very this is a very important slide for everybody to understand, because our genetic counselors from the NIPT team make a special effort to get the follow-up information. Because when a high-risk result is sent, we need to understand what was the outcome. Did they go for further testing, and what was the result of further testing? And we are actually quite proud of this data, because we see that for trisomy 21, the PPV is about 76%. And please sorry. Compare it with the ISPD and the ACMG value. We are at 76%, and for trisomy 18 it is 55. For trisomy 13 we seem to be performing better than the international standards. Monosomy X as well, 37%, and the other sex chromosome abnormalities actually perform extremely well. We do have a very high positive predictive value, and for rare autosomal aneuploidies the positive predictive value is about 10. Now, this information, when we call for follow-up information, there is one unfortunate thing that we have noticed. About 10 to 14% of the time, pregnancies are terminated without further confirmation. I mean, of course, that this is not judging those situations, because we are not aware from this side. There may be other abnormalities, there may be other reasons why pregnancies are terminated, but of course, that is not in any recommendation, and all high-risk results need to be confirmed by invasive testing. Now, why should they undergo confirmation? So now, why these are some of the reasons. Of course, the biological reasons is that, like I mentioned before, there could be a confined placental mosaicism. The placenta may be abnormal or mosaic, as in it may have trisomy 21 and normal cells, but the fetus may be completely normal. So it's only on testing the fetus we will identify that the fetus is normal. So once a NIPT result needs confirmation, the best test will be amniocentesis, because it is the alternate DNA sample that we are going to get, because the placenta actually will probably represent the result of the NIPT itself. So amniocentesis is preferred. Most commonly, we see vanishing twin. This affects sex chromosome abnormalities more than other abnormalities. We have seen cases of maternal mosaicism, and also a couple of cases of maternal malignancy, which give very strange but typical NIPT results. Now, what about a twin pregnancy? In a twin pregnancy also, confirmation is needed, and what is important, I like to emphasize here, both twins need to be checked, because there is no way of knowing which twin is affected when we have a high-risk result. So I'll just talk about sex chromosome abnormalities here as well. We know from our follow-up data that sensitivity and specificity is extremely high. 99% of the time you will get a result and it will be low risk, but in about 0.2 to 0.5% of the time, there may be you get a report, but it is inconclusive for sex chromosomes. So this was something that we followed up. We followed up a few cases, and the data is something which has been published in Vadia journal recently. So what we saw is in 40% of the cases when we give an inconclusive sex chromosome result, 40% of the cases the fetus is normal. About 30% give a history of vanishing twin. There are fetal sex chromosome abnormalities which are seen in about 10% of the cases. So monosomy X, triple X and XXY is what we have noticed. It was not discernible on the NIPT initially performed, but it was a sex chromosome abnormality. But since it didn't fall in a specific category, it will be given as an inconclusive result. Sometimes it is the maternal abnormality like a triple X or a mosaic X, which might give an inconclusive result. We sometimes see that there may be an adverse outcome already, and in some cases, we don't have the information. So I'll just speak about this one particular case, a 30-year-old female, 17 weeks gestation, 1 in 161 risk for trisomy 21 on first trimester screening. 7.4% was the fetal fraction. The common trisomies were low risk, but in sex chromosomes, this is what the plot looks like. She was off the chart. The plot was off the chart. So we gave it as inconclusive. The plot should actually fall in one of those predefined areas which will give a specific abnormality. And because it was inconclusive, they went in for further invasive testing and for QF-PCR. This is actually the QF-PCR result. As you can see, 1:2 ratio, 1:2 ratio, 1:2 ratio. What it actually means is that the mother was actually a mosaic triple X. So we know that NIPT actually is overwhelmingly, the cell-free DNA is maternal and it can impact the results, but in a small percentage of individuals. So coming to fetal fraction, the fetal fraction, of course, is extremely important. We are all aware. And what is an adequate fetal fraction for a good NIPT result? Fetal fraction can be anywhere from 2 to 4%. I know that most clinicians are aware of a figure of 4%. That was some time back. But since 2020, there are many publications and improvement in technology which can lower the fetal fraction below 4%. We do know that there is a greater confidence if the fetal fraction is higher, but that's not the only parameter. There are LLR scores, there are mosaic ratios, there are Z scores, there are several other factors which are the combined data of which puts a sample into a high risk or a low risk category. And unfortunately, the false negatives that we have seen also can occur at any fetal fraction, not necessarily low fetal fraction. Another point to remember is repeated low fetal fraction may be associated with an aneuploidy, and there are techniques with different providers like IFACT. IFACT is Individual Fetal Aneuploidy Confidence Test, which actually provides more reads to a sample which has low fetal fraction so that a result can be given. So actually, it is a dynamic threshold. The threshold that we currently maintain is 3%, but we can go lower. Now, of course, all guidelines do recommend that fetal fraction be reported in every NIPT test. As is very well known, fetal fraction increases with gestation age. The mean gestation age at which people in India tend to do NIPT is about 16 weeks, and mean fetal fraction is 9.3%. And of course, with maternal weight, there is a decrease in the fetal fraction, though we have had results for even women above about 150 kgs. Now, what we want to say here is if the woman is obese, maybe just a little bit of counseling that a redraw may be required, may be sufficient to actually improve compliance with a redraw and reduce the worry as well. Now, what about NIPT in twins? We know that twins serum screening probably does not work extremely well, and also invasive procedures screening for aneuploidies have complications, and that's why NIPT. This is one of the meta-analysis in 2020 which has shown that the sensitivity of NIPT or detection rate for NIPT is about 98%, which is similar to singleton pregnancies, and so is the detection rate for trisomy 18 is 93 and trisomy 13 is 75. So up to 2020, no guidelines would comment decisively about use of NIPT in twin pregnancies. But in ISPD position statement in 2020 said that NIPT is the most sensitive screening test that you can use for multiple gestation. We have been using NIPT on twins for about 7 to 8 years now, and this is our data. We know that 3.2% of all pregnancies are twin gestations, and 2/3 of these are by assisted reproductive techniques, and about 69% of those, 60% of those would report as IVF self-eggs, and some of them, about 30%, will be IVF donor eggs. The reason I put this busy slide is we find that the mean fetal fraction for twins is not double of a singleton, but it is slightly more than the singleton. But this is a good enough fetal fraction to give a result. Obviously, no-call results will have an average, a much lower fetal fraction, and we do have a cutoff about 4 to 4.5. For twin gestations, below which we do not report. And this is, of course, ultrasound data, dichorionic diamniotic pregnancies in about 72% of the cases, and monochorionic diamniotic in about 8.8% of the cases. So how does twin data look like? Of course, 95% of the time would be a low-risk result. 1.4% we found high-risk results, and redraws were slightly more. We know that for singleton, it's about 1 to 2%, but for twin gestations, it will be about 3 to 3.7%. And even on a redraw, the possibility of getting a result is about 60%, 58% only. So this is one case. Again, another case which I'd like to share, a 33-year-old primary, spontaneous conception, 14 weeks gestation, and ultrasound. It was a dichorionic diamniotic pregnancy. Fetus 2 nasal bone was not visualized. What we found on NIPT is it was high risk for trisomy 13. Fetal fraction was good enough at 8.4%. But here what happened was the fetus 2, I think they decided to terminate the fetus 2, in case of cardiac abnormality. And then fetus 1 then came for invasive testing. The QF-PCR actually was normal. We know that QF-PCR actually looks at whole chromosome abnormalities, not segmental losses or gains. But the CMA actually showed that there was a gain in chromosome 13, though the region was very small. So sometimes NIPT does pick up. It may not be a full chromosome abnormality. It may be a segmental or a specific arm gain or loss, which can be picked up. So for the summary of twin pregnancies, of course, it is the risk is per pregnancy. High risk result requires confirmation. We cannot tell which twin is affected, and a slightly higher fetal fraction is required to make a call. But a low risk result again has a very high NPV. That means the negative predictive value is very high even for twin gestations. Now, when we are talking about twins, what about vanishing twins? We know that about 10 to 30% of twin gestations end up as vanishing twins. Sometimes we do not have that information on the TRF. Only on ultrasound, we notice that it is a twin gestation. Now, the reason why the other twin might have expired maybe because of an aneuploidy. So the possibility of a high risk result is high. I mean, it is possible that you might get a high risk result when there is a vanishing twin. But should you do it or should you not do it? Should you wait? See, as such, the guidelines initially were not too keen on doing NIPT for vanishing twin. But recently, ACMG states that there is no evidence not to do it also. I mean, of course, it is, if you can understand and you can state very clearly, okay, you have the ultrasound report that this is when there was a twin demise, or if there is enough information, and if you can wait as long as possible to do NIPT, you will get a result. So far, we have done quite a few vanishing twin results, and there has been no adverse outcome so far. Of course, it goes with a disclaimer that there is a slightly higher risk of false positive results. What about rare autosomal aneuploidies? This is advanced NIPT. So we look for aneuploidy in chromosomes other than the common chromosomes. The natural incidence of rare autosomal aneuploidies is about 0.35%, and it's the genome-wide NIPT which detects this. So we see that the most common result that we see is for trisomy 7 is most common, after which we see trisomy 9, trisomy 16, and trisomy 12. So the PPV that we have had some true positive results. So 10% is our data. Meta-analysis says anywhere. I mean, we saw that data before. It is about 11%. So why is it important? It does have an impact on the pregnancy because if you do an invasive test, of course, an invasive test should be done ideally to identify whether it is a true positive. 50% will be normal on invasive testing, but other 50% seem to have some sort of adverse difficulties, as in with growth restriction, with intrauterine death, or fetal mosaicism. Uniparental disomy is a definite risk. Of course, for this, counseling is challenging because 80% of these abnormalities are confined to the placenta, but they might have an impact on the pregnancy, and it should be closely followed up. We did have one, this is the true positive case which we published. What about NIPT for microdeletions? Again, microdeletions, it is available, it can work, and there is support for looking for microdeletions for 22q11.2. We know that only 70% of DGeorge actually may show abnormalities on ultrasound scan. Many of the others may not show abnormalities on an ultrasound. So as such, there is no screening test for many of these abnormalities, and NIPT will be able to pick up, but we know that the PPV is much lower. There is a high false positive rate, and again, it has to be confirmed with an invasive test. So let's come to some of the limitations of NIPT. Of course, very, very important to emphasize, it is screening, not a diagnostic test. There can be no call, though the no calls again are very few, about 1 to 2%. Low fetal fraction may be a problem. It could be associated with early gestation. It could be associated with increased BMI. And a redraw is one of the solutions. 80% of the time you may get a call on a redraw. Confined placental mosaicism is a specific biological factor which should be considered when you think about NIPT, and there are certain maternal factors which may be involved. Cost and access, of course, is another factor which can be considered or should be considered during while offering NIPT. Coming to false positives and false negatives, these are definite possibilities, and it is because of how the cells segregate and mosaicism restricted to the placenta or present both in the placenta and the fetus, which leads to these abnormalities. There is also a small possibility of an incidental finding like a maternal neoplasia. So I'll just describe this case. It was a 36-year-old woman. She came because of two soft markers. It gave a very abnormal NIPT result. There were trisomies in several chromosomes, monosomies in several chromosomes, which is a specific pattern for malignancy. And we had specifically said redraw is not recommended because we know that this is going to repeat, and we can't really tell whether this represents the fetus. And but the patient went elsewhere and the sample came again, and we saw exactly the same pattern. And when the clinician called me, she said, "Iska kyun nahi diya?" Then that's when I told her that there is a possibility this pattern is indicative of malignancy. And the mother actually had fever and cough. They suspected bronchopulmonary aspergillosis, and she did not respond to antibiotics. Chest X-ray showed no definite lesion, but a CT chest showed lymph nodes, and an an ultrasound-guided biopsy actually showed necrotic cells. They again thought it was tuberculosis. They started treatment for tuberculosis, but then the histopathology finally showed that it was a Hodgkin's lymphoma. So this is one of the case, and there was one other case which we have put together in this publication. So this is a very small risk, but sometimes very strange NIPT results can indicate a malignancy. But how you're going to counsel the patient after that, of course, is the biggest challenge, which we can discuss later. And these are the points for pre-test counseling, of course, very clearly telling that it's screening and not diagnostic. And we are looking only for specific conditions and what are the type of results that you can expect, because sometimes they may not be ready for a high-risk result, may not be ready for a no-call result, and incidental finding. There may be a small possibility of a redraw, and of course, what is a regulatory scenario, and we should be able to complete our screening by at a specific time. And once the result is there, then we need to know what is the if it is a high risk result, it has to go for invasive testing. That if they are prepared beforehand, maybe their compliance is better. And sometimes if there are no results, there may be alternative testing which may be needed. Now, these are the new applications, which is what I'm quite excited about it, NIPT for early pregnancy loss. So if this is something which is coming up now, if there is a fetal demise early on in pregnancy, an NIPT may be able to give you a result, because we know that most of these are associated with aneuploidy. So what it can avoid is collection of the POC sample and metadol cell contamination, which kind of prevents getting a result many times. So this is one of the application. Other, of course, is single gene disorders, which has been around for a while. Then NIPT can also be used for, or it is not the DNA, but the RNA, which can be used for testing for preeclampsia. This is something new. And gestational diabetes, fetal growth restriction, this is something. And just give me a minute. Yeah. And this is something which is very close to my heart. Can NIPT become diagnostic? There is, just one second. There is a proof of principle now that circulating fetal cells can be used for testing. So they have been able to isolate 16 on 16, which have identified aneuploidies as well as microdeletions. This is the proof of principle, but this can actually bridge the gap from screening to diagnosis if the fetal cells can be identified, proven, and an abnormality identified on that. So let's wait and see where this goes. Coming to the conclusion, NIPT can be offered to post-pregnant women. It is highly sensitive and specific. Follow-up information is requested from all clinicians. Pre-post-test counseling is extremely essential. Ultrasound is important, obviously. Before NIPT sample is sent, and of course it's not recommended for in certain situations when there are severe abnormalities on ultrasound. Termination without confirmation is a worrying trend which we have observed, and there are limits of the test have to be understood, and occasionally there may be unexpected results. Thank you so much.
Thank you, Priya. Fantastic lecture. You've covered all the basics, all the details which are of importance in practice, and you've given your own data. It is really nice to see, the actual data, because I know from Vadia we were sending samples to MedGenome over the years, huge volume of samples. So I'm sure many of our patients are there in that data.
Yes, certainly. Yeah.
One question I wanted to ask you, you mentioned that if there's a no call, you should draw a sample after 2 weeks. Why is it?
We hope that the fetal, 2 weeks from the first draw. 2 weeks from the first draw, because once you set the sample, it takes maybe 1 to 2 days to come, and then we give you a result within 7 days. We expect that the fetal fraction has increased a bit. Many times the reason for a no call is a low fetal fraction,
Early
below a
gestation.
cutoff. Yeah.
Early gestation. Okay.
Yeah.
Thank you.
Yeah.
There are some questions in the chat box, but I think we'll come to those later. I'm just wanting comments from Dr. Pratima and Dr. Chinmay, or any questions that they would like to ask.
That was an excellent talk, Priya.
Thank you.
I just wanted to see your slide, it went very fast. The one just before case 2. I think it was data on twins, NIPT with twins.
Yes.
Pratima is the twin specialist.
I know. It just happened to be. Yeah.
Which one?
No, it was just the slide before twins. Before case 2, sorry, before case 2.
Case 2.
Yeah, that would be in that section only. Yeah, before this, yeah. No, before.
Before this.
One
This.
before.
Yeah. So we're just looking at your data there. No,
No, the one after this. Yeah.
3.2, 94%, 1.4 redraws. So your redraws is slightly higher in twins, which is what is expected, isn't it?
But there's a no result for 43%.
43%. Yeah.
Yes.
So
yeah.
I think the other thing is also you need to
yes, this is also unusual because in singleton about maybe no result about 20%.
Yeah. So it is how many total samples were there, twin samples, and you said 5-year data then? Is it 43% out of the
Pratima, I lost.
Hello, sorry.
Yeah. I think she got disconnected, Priya.
I think Priya got disconnected. I thought
Yeah.
we can meanwhile kind of discuss the questions. Priya.
So I'm sorry, Dr. Pratima. Actually, I lost you.
Okay. No, we lost you too.
Yeah. Now it's back.
Yeah. No, I was just looking at, is it because 32 is out of, I mean, if you put
74.
the numbers,
32 is out of 74.
It's
out of the 74.
less than 100
Yeah.
samples.
About 74.
Yeah.
Because see, we request for redraws totally in about 3.7%.
So final no result should be actually your 43% sounds too much. Actually, it won't be that much. It should be out of the total number of samples, no?
Yes, that's right.
That's right. Because 43% suddenly looks too big a number.
Yeah.
Which is not the case.
43% of 3%, 3.7.
Yeah, absolutely.
No, of the 3.2%.
Of the yes.
Topmost.
Because
the topmost number.
Yes.
But there is no number there. So
yeah. You're right. I mean, this what we want to say is in how many cases you're going to get a result and how many you won't.
Yeah. So if the moment you get a redraw, I just say there is a 50-50 chance that you will get a result.
Yeah.
And that's what it is. Yeah.
So 3%
but then there should be some high risk also, isn't it, in the redraws?
Yes. Maybe I think in this cohort we don't have.
Yeah. Twins will be a smaller cohort anyway.
Yeah.
Because redraws also will go into either of them, either high risk, low risk, or no result.
Absolutely.
Okay, fine. Thank you.
Yeah.
Thank you.
I think that's it from my side. I think we're happy to take on the questions.
There are very wonderful questions as well in the question answer box.
Should we take them at the end?
At the end?
We'll go through our cases and then come back.
Yeah.
We might actually cover in the cases itself.
Yeah, sometimes, it will get resolved in the cases itself. Yeah. Chinmay, you want to have any comment?
No, sir, that numbers which ma'am was saying, I think that 3.7% or, I mean, whatever 3.7% of the full data is 74. So that way the number would be higher up there, isn't it?
Correct.
Because there is only that 74 number given, which constitute 3.7% of your data. Isn't that correct?
That's correct.
Yes. But still over time, it has gone down drastically low, the no sort of the answer, because I remember in around 2000, it was very high. I had sent samples twice, thrice, and they used to say no yield as it. But now that particular thing has drastically reduced, though the exact number or data we don't have.
But like Pratima madam said, I think that is the observation that I also have, that in the no call group, usually the recommendation is if there is repeated no call, you go for an invasive because the chances of having a problem is high. But in your data, the no calls have all come out as low risk or no result again.
Yeah.
And the
Yeah,
no
but we
result
took
again,
it.
did you actually then go ahead and do like invasive, or what did you do with the no result, which was finally no call?
It will be, I can actually pull out and tease out that data. The thing is, I mean, sometimes we don't have the follow-up.
Mhm.
I think it would be a bit of a challenge for a laboratory to put that data presented because of the varied number of clinicians. See, other thing which would be very interesting, Priya, is actually to look at the indications for the NIPT. Because I think the success of NIPT story heavily depends upon why you're doing the NIPT in the first place. False positives, you're not so worried about because you have a backup plan. You
Yes.
do an invasive and you sort it out. But
Yes.
I really, really worry about false negatives, right? And it can happen. It can happen. It has happened.
Yes.
Yeah.
Right. So that is, I mean, if by chance for some God-given reason, they end up with an invasive for any other reason, good. But if they don't do an invasive and they continue, then, especially the
The
test being where it is postured in the community at the moment. Oh, NIPT
Yeah.
means everything is perfectly okay. That's the impression majority of the people have. And in that situation, if the baby is born with a trouble, baby. I mean, of course, the lab is fantastic. It gives you 4 pages of disclaimers and 1 page of report. That's brilliant. But as clinicians, we are only looking at the bold letters, right? And not at the disclaimers, right?
Yeah.
So
That's
I
why
think
out of all the various guidelines which are there, the ISWOG one, it emphasizes that along with a very good first trimester scan. And I think that's extremely important.
I
Exactly.
think
Yeah.
the scan is extremely and,
Yeah.
and the reason why you do NIPT, I mean, why are you doing the NIPT in the first place, right? The indication when you do NIPT for, you know, just like that kind of doing an IPT, just for the sake of doing an IPT versus an indication-based NIPT, again, your PPV will vary.
Yeah.
Yeah.
But people are
Just
asking for it now. People are asking.
just today, ma'am, I've had a patient about an hour back who has conceived by chance while she was on Monjaro. So
Mm.
she didn't realize because she had irregular cycles. She didn't realize. So today she came for an NT scan. The scan is perfect. So her question is also the same. Shall I get
Yeah,
the
we read
NIPT done?
about. Yeah.
So
I
the
think
NIPT is
that's
not
Now
going
we
to be
have
fantastic
the
to get
solution.
marketing,
data.
isn't it?
No, we have to get data on women on Munjaro. I
Yeah.
mean, there isn't
True.
any
Right
data
now,
yet.
there isn't
Yeah.
much. There isn't
Yeah.
much.
Yeah.
But then, whatever you would suspect would be in terms of teratogenicity, would be in terms of other things. That NIPT is not going to be her solution there. But whatever happens, NIPT seems like a very fancy test to do.
God.
And what is it solving exactly? Nobody tries to understand that.
And
Okay.
actually, the comment by Pratima is really very important. What she says, true disclaimers. Yeah, the same way the one of the patient put, the torch like she said, doctor, you say about not 1%, but what about that? Suppose I fit in that point not one. It is all or none phenomenon for me. For your data, it's okay, but
No,
for me, there it will
that,
be
that's
That
true.
is
I mean,
always the case.
that'll
yeah,
always be the case, Dr. Milind. I tell them
yeah,
it's like crossing a road. I
yeah,
mean,
exactly.
crossing and walking on the road is far more dangerous than the
Yes,
risk of an invasive test.
yeah,
But we
and
don't
that's
stop
why,
walking, we don't
yeah.
stop crossing, we don't stop jumping red lights, we don't wear helmets.
And that's why documentation is again very important
Very,
for
very
this
important. Yeah.
place. It's very important, yeah.
So
Mhm.
thank you, Priya.
Thank you.
I think if you stop sharing, I'll attempt to share mine. I
Sure.
hope it comes.
I'll
Otherwise,
do
you
that.
have
I'll
it.
do that. Yes.
Can you see? No? Try. I think I have to be made co-host or something like that, Just check.
Ma'am, you are already the co-host.
Okay.
But somebody is sharing the screen.
I think we can see your
I think we have
screen,
to
but we
stop
don't see the
sharing by
presentation.
first.
Can you see it now?
Yes.
Yes. Yes.
Right. So we are three of us. We are going to discuss this, and our experts are here. So the first case talks about the twists and turns in counseling. A 34-year-old primie, a super specialty doctor, underwent NT scan and dual marker test at 13 weeks and 2 days. The NT scan was normal and it was done thoroughly well, which we always confirm when these patients come. We look at the images and we make sure that all the information is there. The dual marker test showed a very low PAPE, as you can see over here. And because of that, the risk of trisomy 21 was 1 in 563, which becomes intermediate risk. So let's start with Chinmay. How would you counsel this patient?
So, madam, first of all, the scan is important, and I would reassure her that structurally the fetus is looking normal and there are no structural abnormalities. I would like to see if the CRL is corresponding to the gestational age as expected, because one of the findings that is of note in her clinical scenario is the very low PAPE, 0.18.
Yes.
So the very low PAPE is also a marker for a poor placental function, although it doesn't manifest so early usually, but growth will be something that we are worried about. And right now, I would tell her that baby looks structurally normal. And because of the biochemical imbalance of that low PAPE, the risk for trisomy 21 has come as 1 in 563, which is actually less than her age-related risk. Her age-related risk was 1 in 350. So there has been reduction from the age-related risk, but then we use population-based cutoffs, and in that you fall in the intermediate risk group, because if it was less than 1 in 1000, we would have thought this is called low risk. So because it is in the intermediate risk group, you can go for a better level screening test or a confirmatory test if you want a 100% answer. So I would give her the option of both the things. Why the NIPT? Because the scan is normal. And we really don't mind offering an NIPT in this case if she's not keen on an invasive.
Yeah. So, but because she's a doctor, then we give all the figures and we document it, that what is the detection rate for Downs, which is very, very good, with a very low false positive rate. But of course, amniocentesis will be needed if there's a high risk result. And then we also tell them about the diagnostic procedure, because some of them may want, it's ultimately it's their choice.
So if they want a diagnostic procedure, that would be the first choice always, because that clears off so many doubts at the same time. However, if she wants to avoid a diagnostic procedure, she can have a higher level screening test, which will be an IPT. But then again, if that comes high risk, or no call for that matter, she might still require an invasive.
So I think we just need to tell them that the risk of loss in good hands of amniocentesis is extremely low. And so they need not really be very much worried about that. Now she opted for NIPT after this counseling. And as you can see here, she was very happy to see that trisomy 21 was low risk, but then the Turner's was showing high risk. So now, Ami, can you tell us what would you say to this patient?
Normally, like Priya ma'am also mentioned, the moment you have a high risk on NIPT, it needs to be confirmed before we take any further action. So that would be the counseling from my end, that okay, something has come up, your scans are normal. So we are sure that, at present the fetus looks fine. So this high risk can be a false call also, we don't know. So we need to do an invasive test to confirm, and then we take a call ahead.
So I'd like to make a point here, ma'am, because while we were doing the counseling, I mean, of course, one important thing to counsel them is, because we were so focused on the trisomy 21 bit, and the NIPT has a 99% sensitivity for trisomy 21, we get carried away with that. Whereas when we do the NIPT, we are actually giving a result for a lot many other chromosomes, and the sensitivity is not so strong for all the other chromosomes. So the NIPT, to avoid an invasive invasive test would hold a very significant role in terms of only trisomy 21. But here you looked for trisomy 21, you found a low risk trisomy 21, but you created another indication for further testing. And this could have been the part of pre-test counseling, which even I forgot at that time because I was focusing on the trisomy 21. So this is probably one thing we should tell them.
Yeah, so a very large meta-analysis which I saw recently, it just shows that the false positive is very, very low. I mean, if you get a positive in the NIPT, the false positive is very low for trisomy 21, whereas for sex chromosomal anomalies, almost half of them are a false positive. But I think Priya's data was a bit different. It was not so high, the false positive.
Yes, I think this is combined. This is combined sex chromosome. So actually, it's monosomy X which actually pulls down the pulls up a false positive, because monosomy X tends to be false positive, but the others like triple X and XXY, XYY actually have a very high a positive predictive value also.
Okay.
Yeah.
I think
come in here, Dr. Purnima. Can I just come in here? I think you need to change the display settings because we can see your presenter's view. But what I wanted to highlight is when I see that high risk for trisomy Turners with such a normal looking baby, of course, it could be Turner syndrome, but I think I would get a genetic counseling done there because before I do the invasive, because if I do an invasive and it does turn out to be Turner's, which is a normal, otherwise structurally normal, do they really want to go through a discontinuation of that pregnancy? Because the challenges mainly for these kids will be reproductive challenges. And the same thing goes for Klinefelters as well, right? We've had some parents who decided to continue the pregnancy knowing that there is a sex chromosomal abnormality, versus there are, of course, some people who just terminate. They say that, look, we can't handle this after confirmation, of course. So I think, getting a sex chromosomal aneuploidy, this used to happen even in your dual marker. When we were just doing a combined test, that time also we would get, sometimes increased risk for something, some labs very specifically that they would look for, but then they stopped that. I'm talking about 2002, 2004, when professor was very keen on reporting more than that, and then it was stopped. So I think it would be a good idea to get them more knowledgeable about Turner syndrome before actually doing the invasive test as well.
But then all of them, no? All the sex chromosomal aneuploidy.
I would say
for any sex chromosomal
aneuploidy. Do the invasive test and then do the invasive test and then do the counseling, so that, ma'am, because a lot of them would be false positives.
I think it is 50%, right? 60% versus 40%. So majority will be positive, right? So I want them to be aware, knowingly get into the invasive test group. Right?
Actually,
I agree, ma'am. I would say get the first information and then do the counseling, because sometimes
I think we may agree to disagree here,
Chinmay.
I will always get the counseling done beforehand.
So
right?
I'm going to try and collate the two, because as a genetic counselor, I see both ends. I think sometimes it's useful to have them come in before. The idea is that, in this case, luckily the scans are normal. Sometimes you will have some soft
only
markers.
When the scans are normal. No, I'm not talking about. I'm talking very specifically, Ami, when the scan is normal.
No, let me finish. So the idea is that here, even though your NIPT is pointing at a high risk for Turner syndrome, when we do the test, it may not be Turner's, it may be something else as well. So the idea is, when we are counseling, we need to cover all these points, that even though this NIPT is showing a high risk for Turner's, we also need to look for other aneuploidies, and this might be a false positive for Turner's. And once we have the result in our hand, post the invasive test, then yes, based on the result, we can counsel them that, look, it's Turner's. And like Pratima ma'am said, that Turner's have a good lifespan. They do not have major anomalies. And if scans are normal, then yes, you can consider or take an option of continuing it with all the due risks explained. So it's a mixed bag. And that's why sometimes sending them before the invasive and again after with the result to a counselor can definitely help. Sorry,
Well,
ma'am.
whether you do it before or after, you sometimes get a surprise. Like when we did the amniocentesis and sent for fish, it is showing some low amount of mosaicism here. So as you can see, 2 per
Mosaicism
100
for
cells.
triple M.
learners.
21 again.
Was it 21?
Yeah,
This
3
was
signals for chromosome 21 were seen in 2 per 100 nuclei. So Priya, can you shed some light on this? Does this happen?
Yes, it happens actually. But I mean, it should have. I'm surprised that for 21, there was no, it didn't show high risk, right?
What was the fetal fraction in the previous one for this thing? I forgot.
10.8.
It was good, yeah.
10.8.
Yeah. So actually, this is there isn't clear information on whether the degree of mosaicism and the outcome. There isn't clear data on this. So it is, I mean, I think the entire gamut will have to be explained.
Would you call
So
this a
even
mosaic 21?
No, I believe it's not even significant, but it's not
Less
very
than
think
5%,
above
I
four
think.
cells, above 4 cells is considered significant. Above 4.
So
2 out of 100
here
showing.
the problem
Yeah.
is it's 2 by 100, which is being done in amniocentesis. So correct me if I'm wrong. Can this also be the placental mosaicism sometimes show up this way, or
No,
I'm
if
wrong,
it
maybe.
is
That
no,
is
On the
one thing.
not in
if it is
amniocentesis.
this is amniotic fluid, right?
Okay.
So
So the other thing is 2 by 100 cells, you're getting it in the
I thought we're losing Ami.
Yeah,
yeah.
it's I think from her end.
Do you report mosaic which is significant or rather which is not
when we are
significant?
down mosaic.
Ami, some problem with your speed.
Priya, would you report a mosaic that is not significant?
No. No.
Because so then
We
why
don't.
was the 2 out of 100 reported is my question then.
That's one. And usually what the lab will do is count other cells as well. Another 100
Yeah,
cells.
they count more, isn't it?
Yeah, another
Yeah,
100
they count
cells
more.
because that will give more clarity.
Yeah.
Yeah, they did count a lot of cells, but then they wanted to report it,
And
So then we were still waiting for the karyotype.
If they want to report it, then we are in soup, isn't it?
Yeah, so I mean,
But
you can
they have
imagine.
written there, but they have written there that though 2% may not be clinically significant.
Yeah, that is
Yes,
may
it
not
is
is the highlight.
Yeah,
But
but this is
that's
a
fine.
cancer surgeon. The patient is a cancer surgeon and she wants to know everything. Anyhow, luckily, at the end,
Karyotype, I
the
think.
karyotype was normal. So that is how your counseling becomes so important. And then at every turn, you have to counsel them again, all over again. Okay, so coming to the next case, this is a Gravida 3 abortion 2, 1 in 750 risk for trisomy 21 on dual marker test. NIPT was done at 13 weeks gestation, which was low risk. Patient was reassured and advised anomaly scan. And then you can see that the anomaly scan shows an ARSA. So then she had to undergo an amniocentesis. And so Priya, can you talk about this?
So, see, if there is an imbalance, right, NIPT is likely to pick up. But if it is a balanced, then it cannot be picked up because any low pass whole genome sequencing cannot pick up an balanced translocation. But this does look like 3 Q arms, right?
This is imbalanced, yeah.
Yeah, this is 3. So this is imbalanced. So this should have been picked up. So this will be considered a false negative.
So what was the fetal fraction again here?
11.
That is significantly high. So
Yeah.
you don't expect it to happen.
Yes.
So, Ami, what are the implications for the child and for the parents?
So for the
of such a
child,
report?
it doesn't really change. It's like other Down syndrome only. For parents, it definitely changes because the recurrence risk will probably be higher in
If they are
case one of
carrying.
the parents are
100%.
carriers of a balanced
Yeah, if
21
they are
21
carriers.
Robertson
So we need to test
translocation.
them.
Yes.
So that's the reason she might have had miscarriages and then she had this child which was affected. So every pregnancy is going to have either a miscarriage or an affected child.
So what could be the reason for the false
21
negative?
translocation is significantly higher, no? If the mother has...
100%
Yeah,
almost.
100%.
Yeah. So
But no,
how
this
do we
21
explain that
translocation
NIPT?
is in the fetus. If the mother has that, it will be different to when the father has it as well.
So
Ma'am,
if
they
the
will-
mother has, the recurrence risk is generally
100%.
close to 100%.
Yeah.
Okay.
So that's the point I was making also. So false negatives actually can happen at any fetal fraction. So we need not worry. I mean, if you have a low fetal fraction, it's not specifically associated with a false negative result. That has been our observation actually.
In fact,
Yeah.
that actually highlights very beautifully why it is important to do the ultrasound, and even with an isolated URSA, you can have thing. And in fact, the 4 reasons not to do an NIPT, not to rely on an NIPT, even if it's been done previously, actually is URSA, ventriculomegaly, nasal bone hypoplasia, and increased nuchal fold thickness.
And what happens
and
in
multiple
the
markers, two or more markers, two or more soft markers.
If people come with NIPT, which is low risk, and we see
then you
any of
cannot
these
die,
markers,
then
maybe
you still
again
have
we are
to.
enjoying.
Yeah,
But
just like
whether
that.
that 21 carried by the mother or the father, I think in either case, the recurrence will be 100% because that person, that individual will be carrying only the
Translocation.
Derivative.
So
The
that
derivative.
person himself will contribute to a to chromosome 21. So the other partner has to contribute one, otherwise it'll be a monosomy gamete from that partner. So the recurrence will always be 100% whether the mother carries or the father carries.
So normally when there is a 21-21 translocation, we do discuss about alternative reproductive techniques. Yeah.
So this is the third case. Is it worth the wait? So a DCDA with one abnormal twin, a 35-year-old primary IVF done in Mumbai, and after doing the NT scan, etc., she conceived these DCDA twins, and then she went back to the US in the 4th month when the NT scan and all was normal. Now in California, the earliest place to start all sorts of screening, they have a compulsory NIPT. This is about 4-5 years back. And NIPT was done. There was a no call. They repeated it once more. Then again, there was a no call. And then they repeated it once more. Anomaly scan was completely normal. So each time they took 3 weeks and the couple was absolutely tensed up about this. So Pratima, what are we worried about if the result is a no call?
We are worried about chromosomal abnormalities, of course, either one or both.
And particularly more in twins,
More
right?
so in twins, more so in twins. And we have had a common example between MedGenome and us as well.
Yeah. And how many times would you repeat before advising diagnostic testing?
If it's done once, I'm committed to NIPT only once. As a principle, I don't repeat it because I've had problems with no calls, and every no call you're losing 2 more weeks.
Yes, and you want to do the selective feticide
and
as early as
twins,
possible.
If you are if you have discordancy in twins, you want to know. I mean, see, I think we need to. This is why I said we need to understand why are we doing the NIPT. We are doing an NIPT for early diagnosis. So if we want early diagnosis, early screening, we have to focus on the job and get it done early. So doing repeat after repeat after repeat is no. But even when I counsel parents for the first time NIPT, I tell them you get only one chance at NIPT with me.
Exactly. So the CMA report came at 23 weeks, 4 days, male twin. They tell the sex over there. So luckily for us, male twin normal and female twin has DiGeorge syndrome. So Priya, could NIPT have picked this up?
Yes. It could have. The test that she did, was it just a basic screening or it included the microdeletions?
It's basic screening. I don't know if they are doing higher tests now, but at that 5 years back, it was basic screening. And I think around that time in India, we were still doing dual marker test and we were not very sure about doing NIPT in twins.
Yes, microdeletion testing would have picked it up because the sensitivity as such is 97.
In twins as well, because you have the similar situations, isn't it? The twins.
Yes.
Because again,
twins maybe a little more. I mean, there isn't too much data on twins for microdeletions.
Advanced,
So So that's
Because
again,
again,
I
the
mean, I'm
masking
really,
effect can happen, isn't it, in
yes.
twins?
So the
Yes.
couple was called on Monday and they said you have only up to Thursday to decide whether to undergo selective termination, and you are 24 weeks, so you'll have a 15 to 20% risk of preterm birth and then loss and otherwise prematurity, and they were really frightened. And so the old father started coming to me, can you do anything? I said, see, I can try and go to court and take permission. That time it was not, the gray zone was there. So they can come back here. I cannot guarantee, but I'll try my best. So then we had a very long thing with the court because every week they wanted a report. They were very, very skeptical because female had dejudged. So, so the patient was coming to me every week. I was giving a report to the court and all that. Then they said that again, anomaly scan was done a couple of times, everything normal, both of them growing well. So they said, I think there has been a mix up of the samples in the USA. You please test. I think it will come normal. So then we had to repeat it and we confirmed it. And then we did a late reduction at 32 weeks after giving steroids. So for that, we had to take the court permission actually, because normally in those days, they used to say that do it within 24 hours. The report used to come like that. So they were really surprised. So anyway, the baby is doing very well. So the lessons learned was that no call should raise a suspicion of abnormality. NIPT is the most accurate test for aneuploidy screening in twin pregnancy, and a fetal fraction should be slightly more for us to be comfortable. Although this does not tell us that, if it's 8%, it doesn't mean it is 4 and 4%. It could be all coming from one twin. But I think if it's a little higher, on the higher side, we are happier. The first trimester anomaly scan and soft marker detection, like Pratima was saying, is very important in twins. And there is a possibility of early confirmation by CVS and selective feticide. And if the pregnancy has crossed 16 to 18 weeks, then late termination can be offered. Now coming to the last case, more is not always better. Non-consanguineous couple, elderly 40 years, IVF conception, self-gametes. Dual marker showed a high risk for trisomy 21 and intermediate risk for trisomy 18. NIPT showed a high risk for sex chromosome trisomy. Ultrasound was normal. Now, when the amniocentesis was done, it showed again a sex chromosomal trisomy. Fish also showed the same thing. So, yeah. So, Pratima, how would you counsel her?
I think I will take the help of the geneticist, of course.
Yes. So, this is Ami's case. Ami, what did you talk?
Yeah.
So in this case, generally in India, the problem is we don't know the sex of the child. We are not allowed to share. But I think Priya ma'am will agree, we do have some conversations under the table to make sure what we are dealing with. And on basis of that, we do give an idea and counsel the parents what we are looking at. Most of the times, your 47XXY and 47XYY may or may not really do well. The ones which do well, where scans and everything are normal, is generally the triple X ones which are there, females with
I was going
triple
to
X.
ask you, it could have been a triple X also, isn't it?
Yeah.
It could be a triple
So
X.
those ones generally do much better, and they are known to have, I mean, I have frankly adults who have been by mistake diagnosed to have triple X on a karyotype for recurrent losses. So they are absolutely normal with no abnormality. So it's very important on how we counsel them and to follow up, basis the scan. But yes, there are times when it's very, very difficult to fall on either one of them, and then it's their call to take.
Okay, I'd like to make a point here, ma'am, because the PCPNDT Act clearly says that when there is proven chromosomal abnormality or proven sex chromosome abnormality, one can look at ultrasound features. So I think once the amniocentesis has emerged with this kind of a chromosomal abnormality, then scientifically it can be dealt with all the ultrasound features. And as a lab also, sometimes you report homozygous for X-linked recessive conditions, and this is exactly the point I'm bringing up again and again with you, that the PCPNDT Act has its own provisions for these conditions. So let's not go all
No, so Chinmay ma'am, I'm not blaming it. My idea is that the ones who are dealing with it, they know how to find it out. But that doesn't happen to everyone.
No, all of us should do, because we cannot say that we will have curbside consultations for this, because there is a provision. So once you have a proven chromosomal abnormality, then you take, just like if you are in doubt, consult your DMHO and get the information and do it, because that consultation is possible.
So that's what I do. When they come to me, there is a call which goes to the sonologist to ask what was the ultrasound finding, and the other call goes to the lab to confirm that finding before I even start counseling. So that's the pattern that I definitely follow, so that we can give them a clear-cut idea to take a
And
decision.
once there is a proven chromosomal abnormality in your report, it can be written that, because
Yeah.
of this
It's
abnormality,
written.
it was
It's
checked
written
that.
in our papers. It's written in our papers that this is the likely diagnosis, and it's been shared along with the other information as well.
Yeah, so this being it's a very emotional thing for IVF patients. So after Ami's counseling, the patient opted to continue and had a
So
little.
sorry, this was
Yeah.
actually like Pratima ma'am said, this was actually a 47 triple X syndrome.
Okay.
And on basis of that, because all the scans and everything was normal, that's why they were counseled. And it was a precious pregnancy, elderly couple, so they decided to take a call and continue ahead.
Yeah. So unfortunately for that, because of several complications which she had, she was readmitted 2 months, and then she succumbed to her illness.
Because
So
of
These are
the
more
I
FGR.
just wanted to
complications
I just
of prematurity rather than
Yeah.
the
Correct, exactly. I just
Premature,
wanted to point that out, that
premature and
the child was
FGR.
evaluated and there was no dysmorphism or congenital malformations. And we can clearly see that, whatever led to the illnesses was not due to the triple X factor. So it was probably the prematurity and the NICU stay which sort of triggered it out.
So when we report these, then it's very difficult to counsel them. The family is in a dilemma. So there is a little, difference of opinion whether we should be reporting these at all. The guidelines say that yes, we should be repeating. I think ACMG and all, they say that you should be reporting it. But I just wanted to ask our experts, what do you feel about this?
Yeah, I think it should be reported, Bam. Once there is a finding, it has to be reported. We just all have to get mature enough to handle the information. Suppressing information is not the way forward in science.
Pratima, you also agree?
Yeah, I would agree with that. I think once you see it, you've seen it. You cannot unsee it
Yeah,
anymore.
that's true.
And that goes
And the
with
only
scans, and that
thing,
goes with and then with the kind of information overflow that the patients are having now, and huge amount of medical legal issues. I think it's best to keep it very transparent, report, and let them deal. We don't need to deal with their anxieties.
Right.
Their anxiety is their personality. It's got nothing to do with me. I have to give the information. So when they come and tell me, oh, that doctor scared me very much, I said, that doctor is not the problem. You got scared. You are it's your personality. The doctor gave you the information. How you deal with it is your problem, right? I mean, my job is to give you the information, right? And if you go and make it worse by Googling and ChatGPT and this BT and this, I mean, that's something that you have to deal with. I can't help you with that. And I even tell them, I said, once I step out of this room, I forget who you are. I don't have a memory. So whatever I tell you in this room and be done with. So I think anxiety is not something that should withhold us. Yeah, I know as an obstetrician, maybe you would have a different perspective because they will come and cry to you.
No, that's fine. They cry all the
Yeah,
time.
yeah. Even otherwise.
Basically, yeah, can I have a
Right.
comment on this as well? Because this is again a very practicality in clinical scenario. Especially some people, they are very much reluctant on the termination, but all something comes in front of them, but still they want to do the screening. And then, there's a lot of discussion which keeps on
Dilemma.
happening between the clinicians and the patient, because they understand now there are certain problems, but at the same time, they don't terminate because of religious background. And then it's a really a very, funny situation. So, yeah, very true that again, the documentation, what is the only answer which we have? We'll have to keep on recording everything, and that can solve. Yeah, true. Yes.
Yeah.
I just
Interesting.
wanted
Currently,
to
I'm
make
sitting on one
one.
trisomy 21, proven trisomy 21 IVF pregnancy, 22 weeks, who doesn't want to terminate from a
Yeah.
low socioeconomic background. What do you do? You just
So
have to tell them plus
I just
everything.
have one comment, and especially with respect to what Pratima ma'am also said. that, what we've realized is there has been a shift, from everyone deciding to terminate the moment you utter the word that something is abnormal, to this little door which is opened where people are ready to accept in certain scenarios, like for example this case, or like madam said, of a Turner syndrome where everything is probably normal on scan, so you expect them to have a not so bad outcome postnatally. So I think from our end, whenever we are counseling, it has to be an open-ended counseling, going on both sides, being very clear that it can have complications, it may be absolutely fine, and give them that chance to take a call, because ultimately they live with their decision, not us.
Yeah.
So like ma'am said, once we are out of the room, we have forgotten, it's not our responsibility. So I think we need to ourselves also change in ensuring that we give both the sides, not just the bad side of it, but the good side also, so that they can take a fair decision, especially in such scenarios where we know that the outcome is, at least a 30 to 50% chance that it can be good.
Ultimately, it is the informed choice of the patient.
Absolutely.
Yes.
So I've had one
Yeah.
farmer whose wife was a translocation. She was carrying that translocation. Maybe it was balanced, I guess, but she was not very intelligent. And she had two daughters, of which the older one was normal, and then she had a 5-year-old who had a translocation Down syndrome. And then she was pregnant for the third time. They came for testing and everything, and that thing came as normal. No, I think he refused testing. After we counseled everything, he refused testing, went back to the village. And every time I would observe that this 11-year-old was looking after both the mother and that Down
The
syndrome.
child,
She was the
yeah.
only one who was intelligent. So
Yeah.
then they sent me a video from there, and the baby was looked at least as if it was completely normal. So I said, thank God, at least second
Especially
one was
when
not
you
affected.
see all those babies nowadays, they are appointed on the airport in the various, five-star
Yes, yes.
hotels. So definitely we'll have to think about it, because the
Rehabilitate.
scenarios may be different. Na? Like especially when you said IVF conceptions,
Yeah.
for them coming out of that childlessness is more important than then they opt for it. So we will have to, then cannot have the confirmative sort of decision on us. We'll have to leave the ball in the court of the patients. Actually, we'll have to explain them everything. That is the only thing which we can do. Yeah.
Yeah, so it's important to understand the test well, take a good family history, look at the risk factors, patient data, like Dr. Pratima was saying, what was the reason why it was done, a good pre-test counseling, proper selection. It's an excellent test when in well-selected cases. Very often, a scan is completely normal, IVF pregnancy, little elderly. We want to do this test because we want to rule out Downs and we don't want to give them an invasive test. Post-test counseling and support throughout the journey. As we saw, there can be a lot of twists and turns in the journey. And it's an excellent test if it's used and interpreted wisely, and invaluable tool if we are here, not like this person over here. So thank you very much. We can come to the questions now. I'll stop sharing. And let's see if there are any questions in the chat box.
Yeah.
Would you like to read them out, Ankita?
Yes, ma'am, sure.
Yeah.
So it's coming from Dr. Rimpi Rajrana. Good afternoon, ma'am, sir. I'm 16 weeks pregnant, age 32 years. My dual marker was high risk positive for trisomy 18. NT and NT scan was normal. NIPT was normal, low risk for all chromosomes. Fetal fraction was 11.38%. Early level 2 scan is normal. Should I go for amniocentesis? Is our question.
Is it a consultation?
Yeah, it is.
I think that should be kept separate.
Yeah.
Okay. Should we go on to the next question?
Yeah.
Cost of NIPT and diagnostic tests, coming from Dr. Trupti Nayak.
I think that's a question for you, Priya.
Priya.
Dr.
No, I mean, I see
I think
that
it varies, isn't it?
it's I mean, this again is something which the commercial team takes care of. We do see that, I mean, from 10 years that we have offering NIPT, I see the cost steadily reducing. But I mean, if cost is maybe this is one of the considerations they can do, because what NIPT does is there is a cost of NIPT, there is the waiting period. But if they have to go for invasive, then again there is the cost of invasive and the tests which they do after that. So I think it is an informed choice in terms of costs as well.
But many
think
labs
also-
are doing the amniocentesis free, right? If the NIPT comes positive.
Not anymore.
That
Not
was long
No?
time back. Yeah,
Not
long
anymore.
time back. Yeah.
Not anymore.
No, I
I
think
think
now it's established. Yeah.
all the labs have unanimously decided now.
Not
Because
doing.
it's
Right?
established
Yeah.
now. I
If
mean,
you do the
it's
NIPT, we are not going to give. So at least that. I think NIPT is a very sophisticated. I believe NIPT is a sophisticated test. It requires good, machines, good analyzers, and I think we have to respect that. And it will come with a cost, right?
Nothing
The
comes
cost
free.
of Down syndrome is far, far more, or
Exactly.
having a child with a problem is so much more. This is a small cost, and let the cost be, whether affordable or not affordable, should be decided by the parents. Why are we here to decide? And for me, honestly, if a test is very cheap, when other labs are offering at a moderate price, I'd be very worried.
Okay, next question.
We have a compliment for Dr. Chinmay ma'am.
Ah,
Dr.
yes.
Chinmay ma'am, my role model, my first encounter was when she came to deliver a talk at Usmania Medical College in Hyderabad during my PG days at Uspania. Since then, I am a great fan, Dr. Zehra.
Thank you. Thank you very much, Dr. Zehra. Good luck to you.
Next question. Role of NIPT in 50-year age mother with IVF conception. Donor embryo was 30 years age. USG is normal.
That's a good question, Priya.
yes. Yes, you can go for it. We can
Is
go
there
for it
anything
because
specific with the technology you would want to highlight on that?
see,
Or everybody is doing the counting method now?
yes, it
Or
is the
any case?
counting method, and because of course here there will be a mismatch. If it was a SNP-based testing and it was a single, I mean, this is a singleton, right? Singleton, all methodologies will be able to give a result.
But she could go for the routine screening as well.
She should.
Because we are just getting biased by the 50-year-old mother, but the embryo is only 30 years.
And I think if you do NIPT, you do a PLGF also there, because a 50-year-old mother is more likely to develop preeclampsia than a 30-year-old
Preeclampsia.
embryo with Down syndrome.
The next part of the question is it recommended for all chromosomes? Is it ratified?
See, as such, a professional opinion is restricted to the basic chromosomes, but the screen actually can look at all chromosomes. We do see a positive predictive value of about 10%. So it can explain some of the losses. It can explain, it can be mosaic at times. So I think when you're looking at 5 chromosomes, you might as well look at all.
I think you'll get a lot of false positive you start.
That's right. That's right. But the incidence by itself is very low, about 0.4% only of all NIPTs. So, I mean, if there is a case in which it has occurred, an invasive test will be needed. It will increase false positives, but there may be something that you might pick up at that time. So we have had trisomy 22 mosaics, we have had trisomy 9. These are actually true mosaics in
it
the
is not
fetus.
recommended. I think recommendation comes from a baseline test, which was high risk, right? And most of the time it will be a high risk for trisomy 21, 18, or 13.
Right.
So,
moving to
we won't go around looking for trisomy 22 or 7 or thing. Incidentally,
right.
we find that.
That's right.
So the indication cannot be look for trisomy 22. The indication has to be based on the scan or the blood test findings.
Yes.
So I think that's the recommendation is a confusing.
So that's why, ma'am, some of the obstetricians are recommending this extended NIPT in cases where the parents are carriers of translocations. And I find that very difficult to digest because it really doesn't solve the problem. So maybe as geneticists, you should put a word out there, because even if it is a unbalanced fetus, it might not show up on your NIPT in the current scenario.
Yes, we can't guarantee that it will show up because mostly the translocations are smaller segments. So if it is unbalanced, there is a chance it can be picked up, but there is no guarantee.
No, but that's what they want. No? They want a guarantee, Priya. They don't want that.
In fact, they would even do a karyotype, or even on the amniocentesis, you would do a karyotype and a chromosomal array to cover it completely when the parents are translocation carriers. So I think NIPT is not a choice at all for people with translocations, parents with translocations.
Yeah.
And you would have done because there would have been a likely history associated with that.
Moving to the next question by Kalpesh Kumar Patel. How to differentiate between cell-free maternal DNA and cell-free fetal DNA in blood sample?
Right. So these are actually bioinformatic methods to identify. Generally, the cell-free DNA from the fetus is smaller in size. And since each of the fragments is read from both sides, it's called paired end sequencing. So the size is identified. So the data is actually skewed towards smaller fragments. And there are about 5 to 6 methods for identification of, even fetal fraction is calculated that way. So you don't physically separate. And one other information I want to give is the fetal fraction is not something you get first and then you get the result. The fetal fraction is a part of the analysis of the algorithm. So it's like sometimes even earlier people would tell me, if the fetal fraction was low, why did you test further? But it's not that you test the fetal fraction first. It's an output of the algorithm. Yeah.
Next question by Dr. Suyog Ratnaparki. Which NIPT is best, especially to detect cell-free
fetal DNA?
In which situation we should move forward towards invasive test after doing NIPT, CFF DNA testing? I think
as such, yeah. As such, see, each of the methods which do NIPT detect fetal fraction in a slightly different way. So if you do NIPT in one lab and another lab, you might, at the same time, you may still get a slightly different fetal fraction because of the method of counting. So I would say that most validated platforms work well. When will you do an invasive test? It's when you have a high risk on NIPT or you have a no call. These are the reasons you would go for invasive. And of course, there may be other ultrasound factors or something else where you may want to go for an invasive straight away.
Ankita, I think all the 3 next questions are interrelated. They can all be taken together. So
yeah, I'll just put it out together. What is fetal fraction range acceptable for singleton and for twins? There are few labs reporting without fetal fraction. Do we not consider such reports?
Yeah.
And again, the last one also, that fetal fraction less than 4 and more than 18. Is there a problem? Should we consider those as normal or not?
Yeah, so it depends on the validation of the lab. So guidelines do recommend anywhere from 2 to 4%. It depends on various factors. Actually, there is something called limit of detection for a specific chromosome abnormality as well. So each of the chromosomes, it is different. So as such, by that you decide the minimum fetal fraction. So minimum fetal fraction that we report at MedGenome is 3%. I actually am willing to reduce it to 2.5 because it will give you a reliable result and you will reduce the number of no calls. Okay, that's because it is robust even at that fetal fraction because of the algorithm. So that's one. There may be other labs. I think there are labs reporting at 2% also, and there some other labs reporting at 4. For twins, we have the cutoff of about 4.5. It's not exactly double of 3, but if we have acceptable values, because other than fetal fraction, there are about 4 to 5 other parameters. It is the LLR score, the mosaic ratio, which if they are in the acceptable range, it will have a robust result. So there are a few.
More than 18%?
I think that we do see, especially in very lean women, we do see a high fetal fraction. We do see, but sometimes it may be associated with some disorders, because they do say some conditions like SLE or mother being on heparin may cause increase in the maternal component, so that can reduce the fetal fraction. But high fetal fraction, as such, we
Is
have
there a
robust
problem? The
results.
question is there a problem? I
There
mean,
is
can
no
they?
problem. No, I mean, at the outset, just looking at the fetal fraction, there won't be a problem.
Moving to the next question. MedGenome is not offering NIPT for twins in Delhi. Why? I think it's
It is
more of a process. Yeah.
I mean, of course, there was the PCPNDT issue some time back, but that is all resolved now.
Next
Yeah.
question.
That was
Yeah.
a commonly faced, scenario. Like many of the cities, they had this, the interpretation by the appropriate authority about this test, because when it started, first it was utilized for the sex examination abroad. That's why many of the authorities were against NIPT. You are very correct, Priya. So even laboratories were needed to do a lot of perseverance.
No, I mean, you don't throw the baby with the bathwater, right?
Next question. A young 25-year non-consanguineous diagnosed with choroid plexus cyst. Her quadruple marker is low risk and NIPT was low risk. Should we still need an amniocentesis?
So this is the question which Pratima ma'am was asking. Why are you doing the NIPT in care? Because she is 25-year-old. You say non-consanguineous, which means you're not looking at the risk of unknown genetic conditions. She has choroid plexus cysts. Choroid plexus cysts are generally innocuous. Now that we do scanning so diligently, we know that most of them resolve on their own and they are not brain defects or associated with risks of any problems. They had an association with trisomy 18, but if you have a baby which is scan-wise normal, well-grown, with open hands, without any other markers, very unlikely to be trisomy 18, then you have a quadruple marker which is low risk. So what was the indication of the NIPT here? Why was an NIPT done in the first place? And if it was done and it is low risk, then why is the question about amniocentesis there? Because the purpose of screening is to detect who needs an amniocentesis. If your screening is low risk and you still have a doubt about whether I need an amniocentesis, then what were you screening for in the first place? So I don't think, there is a need for amniocentesis here. Pratima ma'am, Purnima ma'am, you can add.
Maybe she's
Do a
missed
good
her
scan.
first trimester screening and the NT scan. It looks like that, because why would somebody do a quadruple marker?
No, they had a quadruple
When they
marker.
saw,
Till that point, I'm okay. But why did they have NIPT if the quadruple
Yeah.
marker was low risk?
Yeah, but I think
You
I
have
would,
to,
I
it's,
might say,
what you said, doing more is not necessarily more,
yes.
right? But I think what she needs is a really good ultrasound scan by somebody who does good scans.
The problem is the radiologists
trisomy 18.
say choroid plexus cyst, please do quadruple marker.
Yeah.
And then it gets done and the patient comes,
I think you should include radiologists in these sessions as well.
Yeah, next time.
Next question. Is it possible to get a recording of the session?
Yes, we'll speak to MedGenome for that.
Next, what's the cutoff?
They have to become members of ISPAT first.
Yeah. What's the cutoff gestation for doing NIPT?
10 weeks.
So when do you see, as such, you start off at 10 weeks, but technically it is feasible to do just before delivery as well. So there is no cutoff. We can technically do it from 10 weeks onwards.
Yeah. Next question. Low PAPE with high chance of poor placental function. So even though in case number 1 intermediate risk, should we offer direct invasive testing as there are increasing chances of low fetal fraction and increased chances of no result in NIPT? I think this was...
this question is like, if you have a very low PAPE, does that automatically preclude an NIPT because you could have a low fetal fraction? Dr. Priya?
I think this is a very clever question. Very good question. I was also thinking with a fetal fraction of 0.18, would I be...
With a PAPE of 0.18.
Yeah, PAPE being so low. And the concern is you'll get a low fetal fraction, because they all are placental source.
Right.
So I think it'll be interesting to know how often do you get very low, because I'm sure in your data you'll have a lot of high risk
You can
trisomy
correlate
18, 21 as well with a low PAPE.
Right.
So how low is low for us to say, okay, this is too low for an NIPT? There are
Right.
chances, because we are sitting here at 20, 21 weeks gestation most of the times.
So, as such, I mean, we have not looked at this data, so this is something that I want to look at and see if there are any publications. But to kind of straight away think that this will lead to low fetal fraction, it
I
may
think
numbers are
not,
good.
it
the
may not
particular
happen. Yeah.
cases where they speak about is the ones where there is low HCG as well as low thing, where there are altogether
Nothing and
small
low.
placentas like in trisomy 13 and trisomy 18. The
Right.
chance of getting a lower fetal fraction is higher. Whereas in Downs, if you remember, not only there will be low PAPE, there will also be high beta HCG. So in that case, I mean, it's unlikely that you will have low fetal fraction per se. But because even in 13 and 18, some of the cases we've got the
Get the
NIPTs as high
result.
risk and
Yeah,
then
you
got the
can.
results.
But
Yes,
the thing is,
yes.
how much do you wait? I mean, it's not a
Mm.
bad idea.
It's
Both
a
ways.
yeah,
But I think
to
the
correlate.
number was 1 in 500, and that is why I think the inclination towards doing a NIPT was more, looking at the numbers and not just at the
Numbers.
biochemistry, because I'm sure the NT, NB, everything would have been, actually beta HCG was 1.43, so that was a little bit on the higher side. As
Correct.
well. So if you had looked only at the biochemistry, maybe you would have got a significantly high risk for trisomy 21. But
True.
your NT-NB was so good that it
Yeah,
kind of
lowered the risk.
normalized it, adjusted it so well. So I think, yeah, that's a good thought
But
process,
ultimately,
I
we
would say.
found something else in that
No,
case.
that's okay. But I think the thought process of the person who's thinking this question is really good.
Nice.
Next question. In case 1, if fish comes out to be normal and CMA is also normal, do we need to test mother's genotype?
If fish is normal
Case
and
1.
okay, that is because if you got a sex chromosome abnormality as a mosaic or something, and the amniotic sample is normal, do we need to check the mother's genotype?
See, usually in a CMA, if we see, say, terminal gains and losses, we do see a specific pattern where we suspect that parent may be a translocation carrier. At that time, actually, it is recommended in the CMA report to do a parental genotyping. So I think there is some background which is missing over here. I think there may be something leading up to this question. So I think
No,
just the
the
question.
This is the
particular
one with
case, the case we discussed where there was a sex chromosome abnormality that was an ultimate outcome.
Right.
And suppose you got an amniocentesis which was normal, the sex chromosome abnormality was suspected on the NIPT, then should you test the mother for that kind of carrier? Like, could she be
Could she be
XXX
the
or?
Yeah,
carrier
it is
of the
fully
turnout or
possible.
a
It is
mosaic?
fully possible because we do, I mean, I did show the
We-
data. And because we do MCC and a QFPCR, right? That is compared to the mother. We actually have a preliminary information of the mother there itself. So
We had a case
when
where
we
it was
observe,
there was some the
yeah,
sex chromosomes were not reported. They said uninterpretable and this, and when we tested further, the mother turned out to be XXX.
yes,
Yeah.
yes. So like I showed also, 6% of the mothers are do have some issue.
But if the amniocentesis
Yeah.
is normal, we are not, it's only of academic interest, right? We know
Correct,
that the
ma'am.
fetus
Yeah,
is
yeah.
normal.
Yeah,
We would not
yes,
immediately
yes.
continue the testing. We would just reassure.
Yeah, there is one comment by, I think, Dr. Ajit Gandhi, who is also a very senior practicing fetal medicine expert. So I think they can speak. Actually, Ayushi, can we make Mr. Ajit Gandhi to speak, Dr. Ajit Gandhi to speak?
Yes, sir.
Yeah, because he has put in the chat box that he want to speak or do comment on this discussion. Ajit, are you there?
Sir, I've allowed him to talk. You can talk. Dr. Ajit, you can talk.
Yeah.
Yeah, am I audible?
Yes.
Yeah, you're audible, Ajit. You please speak,
Acha.
yeah. I introduced you already, so you please speak, yeah.
Put on your video
Thank you.
if possible.
Thank you, Miling. Could join your webinar finally.
Thank you.
There are 2-3 things. I was listening to your all discussions about that twin case where one twin was a digeorge. Hello?
Yes.
Yes,
Please,
yeah.
go on.
So where any ultrasound findings were there
No,
to corroborate this discharge?
no. Dr. Lulla has only done it, Chandar Lulla. And
Okay.
we saw it in great detail, and there was nothing at all. That can happen though.
Yeah.
No,
Can
see,
happen.
in discharge, there is one thing. There is always thymic hypoplasia. Even if there is no other phenotypic feature, there has to be thymic hypoplasia, which is there in almost 100% of the discharge. So I think
we don't routinely look for thymic hypoplasia in an otherwise normal baby, right?
No,
Thymic
This was even
hypoplasia
after
we
knowing,
resume
he looked at it.
when we see cardiac anomalies, that's when we routinely look for thymic hypoplasia. So it's not a routine.
we have to look for thymic hypoplasia.
No. After it is confirmed DGeorge, yes, but not before. Thymic hypoplasia is not something that is seen on a routine mid-trimester anomaly scan.
No, it should be a part of the, because it's not a
No,
very
it
difficult
cannot
thing.
be a part of
When
it because of one
you look
scan.
at the three vessel view, the thymus is in front of you. Just you have to look at the size of the
Agreed,
thymus.
but there is a lot of false
Visual
negatives.
impression tells you that it is a thymic hypoplasia. It's not a
But
very
no,
difficult
I
job.
agree with you. It's not a difficult job when the baby is looking up and the heart is pointing straight up, right? Many times we see the heart in the lateral view or even in the basal view, which you get very good views of the heart. In those ones, we cannot. What I'm saying is routinely, it's not possible. Yes,
No, routinely it's not
indicated.
possible.
Yeah,
But then
routinely,
you
I'm saying.
find something wrong with the heart. I think thymus
Absolutely,
should
you
be a
should look
part
at
of
it. I
yeah.
totally agree with you. What I'm
Yes.
saying is in routine cases, it's not possible to look at it.
No, not in
Absolutely,
the
you must
routine,
look at
not in
it.
the routine. Yes.
Yeah. Sorry.
But
Then I
when
think we are saying the
when
same thing.
I was in
Yeah.
reference to the discharge, not
Yes,
as a routine
if
part.
you have a proven case of discharge, then you look for all in. I would say you even look at the uvula because you can have clefts of the soft
Yeah.
palate
Yes.
in discharge syndrome as well. So in
Yeah.
a proven case, please look more because you may find something.
Yeah. This is point number 2 is about the PNDT law. See, there is a clear-cut provision in the section 4 that you can reveal the sex when there is a definite sex abnormality related to the sex organs. Okay, and even that extends to the even chromosomal abnormalities also. Why all the labs and all the ultrasound people are scared of reporting this thing because of the fear of PNDT law? I do report when there is an abnormality, and there I quote the provisions of the PNDT law that under this section 4, the clause 3 or something, it is you are allowed to divulge the information. Of course, that information has to be in the scientific language so that patient should not understand very easily. That is the thing. Or second way would be to communicate to the concerned person that this is the thing and this is the abnormality.
Yes.
Yeah. That the PNDT law clearly permits it. There is
Yes.
one should not be afraid of all those things.
I think
Because
there is a dichotomy in the PNDT law that saying if you detect it, you have to report it. I mean, you can report it, but it also says that I did not see the genitalia. Now, how can you detect a abnormality in the genitalia if you don't see it, right?
see,
But in cases like DMD, for
yes,
example,
you are
DMD,
right.
you can
You are
avoid.
right.
Yeah.
You are right. But then that is a flaw in the law.
Yeah.
That
No, I
needs
agree.
to be corrected.
Where
Actually.
it should be detected, it should be,
If it
for
is
example,
yeah.
Yes, sir. In fact, for Duchenne's muscular dystrophy, X-linked disorder, any X-linked disorder, I think labs are so scared. I mean, I'm ready to do the disclosure there, right?
But see, it depends on the
And you would avoid
and
doing
heterozygous.
and you would avoid doing an invasive test, right?
it depends on the appropriate authority also. The previous
Of course,
one
it
used
depends.
to
There are so many
not be
things. These are
supportive. The one
challenges.
which we have now, she's very supportive of this.
I think it's
So it
more
depends
the
on
fear
them.
of harassment more than anything else, to be honest. I mean, it's not the fear of what you're doing because you know you're doing the right thing. The
Yes.
problem is the whole misinterpretation and the harassment that comes behind it is the problem. And the lack of support from, I would say societies and around because it's a hassle.
Yes, sir.
Yeah,
No,
the
but we have
day-to-day
no
problem.
actually
They are
one more
facing that in
point.
Karnataka, you know,
everywhere. Yeah, even
everywhere.
in
Yeah.
Mumbai, actually, I remember they used to, ask us to report the cases of missed abortion under MTP. And, it was a lot of perseverance we needed to tell the AA that no, it is not MTP. But, it happened in some of the ISPAT open meetings as well. The discussion took place when AA was also part of that discussion.
No, see, where we fail is we fail to
Yeah,
put them
yeah,
in proper perspective. We have to be bold
yes,
and tell them that this is the law,
yes,
go through this, and this doesn't come under the MTP. These controversies have happened at my place, and I have quarreled for that, and I got it done. I never
Hats off to you, sir.
submitted to all those things. I have worked in the PNDT committee for 10 years. I know how this committee works.
yes. Thank you, Ajit. Thank
Acha,
you. Thanks.
Milind, one more point about your
Yeah.
this thing. See, when there is when you are carrying out a genetic test, and if there is something like coming with a wrong report, with a abnormal report and termination, there has to be pre-test counseling. That after
Yes.
going through all these tests, if you are prepared to take the decision of termination, then we will go for all those tests. If you are not going to do anything and if you are going to continue the pregnancy, there is no point in doing the test and then wait for the baby to be born and then we'll carry out the test after the baby is being born. Why to subject the patient to all those risks, to the expenditure? And if the patient is not going to take the decision of termination when required, what is the point in doing all that?
Would the information of abnormality not be,
Yeah.
just to prepare them for
I think
what
they
is
have
to
to be
come? Yeah.
emotionally, financially
Yeah.
prepared to have a child with an
Yes.
abnormality as well.
Mm.
Yeah. And sometimes they do change their mind after having spoken to other parents with the same problems. Like I gave you the example of Down syndrome. I have put them through to other parents who are looking after children with Down syndrome. And after a week, 10 days, they do change their mind. So I think preparation is very important.
Should
Thank
I
you, sir.
go on
Thank
to
you for your inputs. Any more questions?
Yeah, ma'am, there are, I think, 35 more questions.
No,
I have
think
answered
it's,
some of them
Yeah, Chinmay ma'am has
on the
answered
chat.
question. Yeah.
I think we have to filter them now.
yeah.
Yeah. You can filter. And one more request to all of them who have put the questions, please join ISPAT. And we can have the
Yes.
whiteboard on the website also with answers to all these questions.
You can have
Because
a
it's
question answer session only,
exactly, yeah. Hello, doctor. Correct, yeah. True.
The one question is, if there are two more soft markers like URSA, absent, nasal bone, then QFPCR with carrier sequences shall suffice? Question. That's the question.
So basically here, karyosec compared with whole exome sequencing. Priya?
Yeah. Sorry, what was the question?
If there are
See, there are two soft markers, okay,
Huh?
and absent nasal bone being a very strong marker.
Hmm.
Then QFPCR is done, which is good enough for aneuploidy. And they are saying karyosec, will it suffice? So, when we get
Yes.
normal QFPCR, CMA, we go on to higher tests.
So actually, Karyoseq is actually a low-pass whole genome sequencing. That is a new technology. It is sequencing, but at low number of reads. What it does is identifies copy number variations, which can be identified by microarray. The positioning of this is it is relatively cheaper than a microarray, and it probably has a wider scope because it is genome wide. Microarray is probe specific, so there are predefined probes. Where microarray kind of has a slightly greater advantage is that it can identify triploidy, it can identify regions of homozygosity, which as such may not have that much of clinical relevance. So any SNP based information such as UPD or the stretches of homozygosity is something that can be identified by SNP-based microarray. Karyoseq will clearly tell you copy number variations.
Will your Karyoseq in this particular case cover for 22 microdeletion?
It can, yes. Karyoseq sensitivity
with full confidence.
Full confidence, yes.
I think if we stick to NIPT related questions would be better. I mean, what do you say, Dr. Milind, Dr. Purnima?
Yes.
Okay. So I'll just read out the NIPT related questions. Next is, should high risk or intermediate risk and contingent NIPT be the way ahead?
Sorry, what's that again?
Should high risk or intermediate risk and contingent NIPT be not the way ahead?
So high risk will be intervention. I mean, invasive.
Invasive.
Yeah. Only for intermediate you could be doing that. We will offer a choice actually for intermediate.
So next question, if fetal fraction is 8%, does sensitivity change? Do we tell different residual risk?
No, I don't think so. Priya?
Yeah. See, there are a couple of publications which show like 1 or 2 points difference in sensitivity as well as positive predictive value for fetal fraction below 4% and between 4 and 8%. But overall, I think it is the same because fetal fraction is not the only component which is looked at when we do the testing and the reporting. There are other factors like what is known as the Z-score or LLR score. There is mosaic ratio. So there are other factors which go into the report. Some of it is seen on the report, some of it is analyzed in the lab.
Next question. Many labs are providing NIPT. What is the criteria, standards we have to look to judge the quality of the labs?
Yeah, I think one major thing is you see whether they are using a validated platform. The other thing is see whether they have any accreditations because CAP is quite rigorous in getting the accreditation, also NABL. And the other thing is whether they have any proficiency testing. Because proficiency testing, again, if you are clearing proficiency testing repeatedly, it gives you good value about the status of the lab. So these are some of the major things.
Extended NIPT versus karyosequencing testing.
So one is a screening test, other is a
diagnostic test.
Yeah, diagnostic.
Yeah. So they can't be compared.
Yeah.
Then should both Form F and Form G be filled before doing NIPT test in a private hospital?
In any hospital, anywhere it has to be filled. Because it's a test that can be potentially detect the gender. So any test that is potentially can detect the gender has to have the G form filled.
Yeah. Will recording be available?
S form is for the scan particularly.
Yeah. Normal fetal fraction range for singleton pregnancies.
I think we've already spoken.
Yeah. I spoke in my talk also.
I think the last question goes is, how does the false positive rate of other chromosomes counseled, and does it not increase more of clinician-patient interaction and anxiety dealing? There should not be a great option to advise. What would be the geneticist perspective?
So I mean, we do counsel for other chromosomes also, like Priya ma'am and all of us have been discussing. Whenever we do offer NIPT, we need to tell them why we are offering that and that it is best for certain chromosomes. We are still not there for all the rest of the chromosomes. So we need to be very clear on that. I think it's not about anxiety of the patients or how we are going to deal with the reports later on. I think it's just being clear on what we are offering. So that's a fair point. I think we can always be open about what is being shared and be clear so that, whatever results come out of it, they can be appropriately discussed.
I think all the questions are answered. Most of the questions Chinmay ma'am has already answered in the session.
Yeah. Wonderful. So I think all the speakers and the experts have done a fabulous job. I have the pleasant task now of the vote of thanks, starting with Milind, who encouraged us to go ahead with this series. This is a series, by the way. This is the very first one. Then thanks a lot to our guests who spared their very, very valuable time, because I know both of them are very busy, Pratima and Chinmay. Thanks to Priya for that fantastic lecture which you have taken. Ami for giving us all the practical points, a pediatric point of view. And Ankita for doing a very good job, both of coordinating and also of, comparing this thing. Thanks a lot, and MedGenome for providing this platform.
Yeah.
Thank you.
And I can see that a majority of the people who attended are still around, listening to the answers. So that's very encouraging for all of us. So
Yes.
Thank you very much,
Thank
Dr.
you.
Millen, Dr.
Thank
Purnima,
you.
for having me
Yeah.
here. And it was a
Ayushi,
pleasure
you
to
have taken
listen
the
to you,
screenshot?
Dr. Priya.
Yeah, Chinmay, if you can
It
put
was
on
nice,
your
Doctor.
video.
Yeah,
Thank
or
you.
video. Yeah, we can have one screenshot. Yeah.
Thank you.
Thank you.
Thank you so much.
Thank
Thank you,
you,
ma'am.
everyone.
It was
I'd
really
also like to
wonderful.
thank Ayushi for organizing as well from
Yes.
our side. It's a lot
Oh,
of
thank you very much.
coordination. Yeah, yeah.
Thank you, ma'am. Thank you so much.
Yeah.
Thank you.
Thank
Bye.
you.
Good
Thank you,
night.
everyone.
Thank you, everyone.
Bye.
It
Thank
was
you.
really fun. Yeah.
Thank you very much. Thank you. Thanks.
Thank you.